Hello and welcome to Everyday Oral Surgery. This is your host, Dr. Grant Stucki. I am an oral and maxillofacial surgeon practicing in Denver, Colorado. The goal of this podcast is to connect, learn, and inspire. In this podcast, you'll be hearing from OMS surgeons all over the globe discussing ways to improve the practice of oral and maxillofacial surgery. Most information shared in this podcast will be based on personal experience and opinions, so please supplement what you learn here with approved research studies. Without further ado, please enjoy today's episode. All right. Welcome, everyone. Welcome back to another episode. Today I'm with Dr. Andrew Jenzer and Greg Tentindo, both oral and maxillofacial surgeons. Thank you guys for joining us on the podcast.
Thanks, Grant. Wonderful to be back, team. Today we have part 3 of our trauma series. We're going to be hitting kind of midface trauma and talking about Leforts, ZMCs, and Orbits in particular. I'm super pumped. I have on one of the legends and OGs of the St. Louis community, Dr. Greg Tentindo. I've got to know him well the last few years, running doing the St. Louis course and with some of our publishing things. So Greg, thank you for being here today. And I'd love if you tell the people just a little bit about your background so they get to know you a little bit more and kind of what you do these days.
All right. Yeah, excited to be on the podcast today, especially talking about trauma. So yeah, I trained out at UCSF, finished back in 2017. After that, moved to St. Louis, where I completed a fellowship in trauma and TMJ surgery, which is run out of Mercy Hospital, which is a level 1 trauma center in the suburbs of St. Louis. It's all run through the practice, the Oral Facial Surgery Institute. And since doing that fellowship, I, became a partner and eventually purchased the practice and now serve as the fellowship director, for that program, which has really grown over the last few years as the Mercy Hospital system has grown and made us that much more busy. Also, I am one of the lecturers and attendings for the St. Louis Oral Board Review course, specifically lecturing on trauma, and then also one of the editors of version 2 of the Blue Book, or what a lot of people call it. So the Oral Board Review course book, which should be coming out in next number of months. But I serve as one of the editors on the trauma section as well.
Sick. I told you I was bringing the guy who really knows what he's talking about today.
For sure. This is exciting. It's going to be legendary. Well, where would you start us off, Andrew?
Yeah, I want to start off with Leforts first. Briefly, and for folks listening, our goal in this is to try to hit a reasonable base of introduction to these topics, kind of like the previous podcasts. They're not perfect. It's not everything. There's a lot more nuance than we can cram into a single episode, but trying to fulfill, really helping to build that foundation for first and second year residents, as well as giving pro tips from the things that we've learned. René Lefort was a French military surgeon. He took 35 cadavers. He introduced blunt trauma. He hit them with wood and metal clubs, stomped them, crushed them, threw them at tables, and then boiled off the soft tissue to look at the hard tissue fractures. And thus is born the name Lefort. Because he really characterized those types of fractures. So what is a Lefort fracture? A transfacial fracture of the midface, really involving the maxillary bones and surrounding structures. And it can be a horizontal, pyramidal, or even transverse kind of direction-y. It generally involves the pterygomaxillary suture and the nasal septum. And we really think about this in 3 kind of categories. Lefort 1, I think about a horizontal fracture just above the apices of the maxillary teeth and across kind of the nasal septum and maxillary sinuses. Typically, they're not too frequently seen clinically. We definitely see them sometimes, but they almost look like a denture, just a floppy maxilla if it's loose, or frequently actually can get impacted backward into the face, kind of resulting in an open bite. Lefort 2 is when it kind of goes up through the orbits and really involves the nasal complex as well, from kind of the nasofrontal region down through the medial walls of the orbit and the zygomatic buttresses. And a Lefort 3 is kind of a complete craniofacial disjunction. Really, it separates kind of the whole face, including the maxilla, off of the cranial base and structures. In real life, you don't rarely see these beautiful Lefort 1s, 2s, and 3s. They do happen. But in my experience, and I'm curious about you guys, a lot of times one side will be kind of like a Lefort 1 and then it goes up on the other side. There's a ZMC or Orbit. Or I find that real life is a lot more messy than these beautiful 3 buckets that we typically put Lefort fractures in. I don't know. What do you think, Greg?
Yeah, generally I would agree, with the exception of the Lefort 1. I mean, you can see some pure Lefort 1s, but just as you're saying, 2s and 3s, sometimes it's this combination or realistically, it's just a combination of a Lefort, with a ZMC or with an NOE. And if you start kind of tracing all the lines on CT, you start deciding, do I categorize this as a 2 or 3, or really just as a Lefort 1 with other, midface fractures? But at the end of the day, categorizations are nice, but as long as you know what to do clinically and how to treat it, these don't quite matter as much. You just try to figure out which buttresses you're going to try to rebuild and what's necessary.
Yeah. Grant, you got any thoughts on the good old Leforts?
No, I mean, I have questions for you just about diagnosing and, what tips you off, and I'm guessing you're going to go there next.
Cool. Yeah. Signs and symptoms, we kind of hit these in some of the first episodes. If they're, especially like a Lefort 1, you can get in there and clinically wiggle, and sometimes it's as loose as like a floppy denture. Commonly, Leforts tend to present with an anterior open bite. The posterior aspect of the maxilla often hangs down and results. Sometimes it's not marked, but in a kind of normal Lefort that is mobile enough, or if it's impacted posteriorly and superiorly, a lot of times you end up seeing that open bite. And that can kind of clue you in that during the surgery, then you need to really correct that. And I want to mention that high point again. Ask your patients for smiling photos before you go to the OR so you can get an idea or understanding of their preoperative occlusion. There's nothing worse than trying to figure that out in surgery, a lesson I've learned pretty painfully. Greg, can you take us through some general treatment options for Leforts?
Yeah, sure. As I was saying before, a lot of these treatment options are very much dependent on, getting your CT scan, looking at the buttresses, clinically examining to see what's mobile. So oftentimes what I'll do is I'll kind of grab the anterior dentition with one hand and then start palpating the midface with my other hand as I try to rock it to see, are we looking at just the maxilla moving? Are we maybe seeing something of the nasofrontal junction moving? Start cluing you in on, your 2s and 3s as well. But treatment options are really dependent on how functional the patient is and how displaced that fracture is. There are occasional ones that fracture minimally displaced, relatively stable occlusion, and you can choose to go with like a non-chew diet, liquid diet for a period of time, or other indications, with mobility or gross movement, we have to do open reduction internal fixation of these, really making sure we're plating at a minimum the maxillary buttresses, potentially the piriforms as well, depending on the extent of that fracture. There's the occasional case where it's minimally displaced, but the nerve has been impinged by, the infraorbital foramen, where there could be some benefit in opening that up and decompressing that nerve a little bit. But oftentimes with those patients, I'll still take a wait and watch approach and try to be a little bit less invasive.
Yeah, that point I think is really critical. There's so many trauma patients that you may evaluate that just have kind of cracks in especially the anterior sinus wall. Like they're not full of Leforts, but they have some element of fractures. And remember, where our nerves emerge from the skull are inherent weak points in the bone. So fractures tend to propagate either along those or into those. And a lot of times you don't need to do anything for treatment for those little cracks they have or small breaks of pieces. But sometimes you see those patients and they're anesthetic. And yeah, I'll usually watch them for a week, maybe a little bit more, but it's one of the things to discuss with the patient that just going in there to kind of relieve those chunks of bone pushing on the nerve can sometimes, and I've taken patients who are anesthetic to, full sensory recovery very quickly in those. So it's like one of those small indications I always think about for just kind of like anterior maxillary wall cracks that you otherwise wouldn't operate on. In terms of approaches, most of the time we do a transoral approach, 5 millimeters above the mucogingival junction. Most residents, I think, of surgeons can relate to that because it's what we typically use to do a Lefort for orthognathics. Just dissecting a bone, it's a pretty safe area. I do want to give one pro tip, and that is when I'm dissecting very small fragments of bone or very comminuted fractures, and this is particularly good for midface and NOE region. If you change your bovie on the cut function to pure, you can then use it to just paint tissue away and it just kind of recedes. On pieces that if you took a 9 or a periosteal that you would normally displace or move, using that bovie to almost paint the tissue away is a really nice pro tip for freeing up small little delicate pieces of bone. So remember that. Usually on the cut function, most of us use it on blend where you get a little bit of hemostatic effect from it. But really to get this gentle tissue release, you have to use it on the cut function, on pure. I don't know. You guys ever tried that or I can't remember. I learned that at some point a few years ago, but I think it's a very elegant way to dissect difficult areas.
Yeah, I can't say I've ever changed any of the settings on the Bovie, but obviously there's the coag and the cut. So we often am using just your more pure cut to get that away. And then also, in my experience though, sometimes getting the proper occlusion on Leforts can be a challenge. We were talking about how you can get some posterior pull from the medial and lateral pterygoids, displacing the maxilla down, leaving you that anterior open bite. So it's important sometimes to actually really mobilize the maxilla like you're doing a Lefort osteotomy, orthognathic type case, to properly get it freed up. There's even been a case or two where I've had to take the reciprocal saw out and finish a fracture to get it fully mobilized so that you can wire them to the proper occlusion and then, get the appropriate reduction. Can be a little bit of a challenge at time with these cases.
Yeah. Pulling some really impacted ones out can be kind of frightening. You have the rows in there, just like a Lefort surgery, and you're kind of pulling and hoping it disimpacts. Yeah. Just in the context of, I think one of the most challenging elements of Leforts is when you have multiple fractures within a maxilla. It's almost like a 2 or 3 piece in the context of a pan face. Because especially with a mandible fracture, you really lose all reference for occlusion. If you're struggling or before surgery about like a really difficult case, don't forget to lean on the intrinsic things we do during orthognathics. You can scan these days. You can scan the teeth and mirror that with a CT scan and get splints made to help you in the OR, or custom plates. Or if you don't have that, you can still snap an impression of the segments and try to fabricate a splint. Vis-a-vis old school model surgery style, but it can be a very effective aid in helping during dealing with those fractures, because sometimes those can be really challenging. Grant, you still with us?
I sure am. Agree with that completely. And
so hold up, Greg, we'll pause for a second. I think Grant's stuck on my thing. Can you see him?
No, I don't see him. I'm good on my end though.
There you go. I think he lagged out. He'll probably hop out in a second. Perfect. I feel like the flow is good. You kind of feel the vibe?
Yeah, definitely. Definitely. Is there anything else you want to hit for Leforts?
No. Yeah, I think move on to ZMCs.
What are you waiting for?
How's the office crew?
Oh, all good. Nice little, reasonably busy day. Nothing wild. As long as the implant's healed, and they're good days.
It's funny, man. I find myself being a lot more conservative in my private practice days than I am at the residency with
yeah, I know what you mean. Because I feel like in that academic environment, I don't know, you just feel like, yeah, we'll do this, do that.
Whatever,
yeah. Then you're like alone in the office. You're like, let's just
you cut me that check. Yeah, no.
I can't do that. No. So what's your breakdown? You're doing how many days in private practice?
Usually 2 to 3 a month. I either take vacation days or do them on like holidays that I have. Yeah, smattering. It's the office is 5 minutes from my house though, so it's so nice. Like if something's weird, or I can pop over for a post stop. And it's one of the flagship CCOFS offices. A big group with like Farrell and those guys.
Mm-hmm. Yeah,
they run their stuff very well. It's like definitely the best office I've been in. That's like, probably like yours, made to support oral surgeons and not like just a general dentist office. So,
right. Yeah. That's one group that I would love to get some advice from. I just feel like they've done such a good job with how they've integrated the fellowship and how they've grown and this and that. And I feel like I've had Rashad reach out before, but we've never really been able to set anything up to and some people don't necessarily want to give out that advice, especially to, somewhat of a competing type practice and fellowship and stuff. But I've always been a little envious of what those guys are doing and how they're doing it.
I'm sure I could plug you in with Farrell if you want. I mean, he's a really good guy. I'm sure he would not mind.
And then what? Because they sold out to the PE some years back, right?
Yep. Yeah. Probably maybe 10 or so, I think.
Yeah. I would just be kind of interested to know how that's worked for them being more of a full scope practice. Because my understanding has always been that the PE guys, don't necessarily want you doing full scope. They want you doing, the stuff that really pays.
No, they pride their business model on full scope. And I think the way they carved out the reimbursement model is like really good, because I think they have maybe 100 offices now in the Southeast and like up to Virginia, down to South Carolina. But I think that was one of and I don't have too much insight, just convos from a lot of like the guys who were on the original 8 that sold out was, I think they structured it in such a way that that was absolutely part of it and could never be touched or jeopardized.
Right. Yeah. Pretty good. Pretty cool. Definitely a insightful group.
Yeah. Yeah. They love to call it Privatemics, which, I think is very similar to what you guys do. Grant just texted me. His internet's jacked up. I said, no problem. We'll just chill until you get back.
Yeah, I wonder how he lost his connection.
Maybe something weird with the good old Denver internet.
Too close to the sun. So how are your residents this year? Your Chiefs pretty good?
Yeah. I have two very solid Chiefs. One of them is going on to be staff at a program, and she's like totally ready for it. And then my other one developed a big interest in cosmetics this year and kind of got back into doing more, not like pretty much everything except like rhinos and facelifts. But I've been I'm the only staff who does them. So, hey, Grant. Oh, you're good, man.
We're back.
No worries. Comcast. I used to have Comcast. Not great.
Oh, all right. You want to pick up where you left off?
Yeah. I don't know if it was that we were just chatting about other stuff. I think we were just finishing Lefort stuff, and so I'll just transition to ZMCs.
Yep, that sounds good.
Cool. And, very close to Lefort fractures as we kind of move up the face are ZMC fractures. And that stands for zygomatico-maxillary complex fractures. And a key thing to understand is sometimes people think, because of the way this looks on combination CT scans, that this is a tripod fracture. The bone really looks like it articulates in those points, but it's important to understand it's actually a tetrapod with 4 main articulations. And that is the frontozygomatico suture, which is kind of up on the side of the orbit, the zygomatico-maxillary suture, kind of where it connects with the maxilla, the zygomatico-sphenoid suture, kind of inside the orbit, and the zygomatico-temporal suture, where it kind of meets the temporal bone and skull. And these are common areas where you see these fractures break along, so it's important to understand. A very common question that comes up on exams, because it's super relevant in surgery, is what suture is the most critical to get reduced for a good reduction during surgery, besides obviously all of them? And the answer is the zygomatico-sphenoid suture. So you can really visualize this inside the orbit. And as a pro tip, a lot of times ZMC fractures, they're inherently orbital fractures because it's part of the orbit. Do you always need to do the orbital component? No, it really depends. Sometimes it's just cracked along there and you might just watch it. If you're doing both the ZMC and orbit, then you can usually dissect and see that suture pretty well. But there's a move that when you're doing your approach, and we'll talk about it a little bit, to access the zygomatico-frontal suture, kind of on the upper outer lateral part of the eye, where you dissect into the eye socket on kind of the lateral wall, and you can really visualize the ZS suture, the zygomatico-sphenoid. I like to do that even in orbits that I'm not opening to really help ensure that my reduction is good. You guys also a fan of that, or like to check that in surgery?
Not routinely. I guess to me, it a little bit depends on the complexity and the level of displacement of that ZMC. Some are minimally displaced, not too hard to repair, but definitely you're one that's kind of, way off, really, displaced, definitely helpful. Or your other option, if you have the option to do an intraoperative CT, that would also negate, your need to directly visualize that. So, but if you don't have those kind of adjuncts available, grossly displaced, probably a good idea, because there's the occasional fracture where you have a few of these other articulations lined up, what appear to be pretty good, and you dissect back there and you realize I'm off somewhere, that you haven't, you've really only reduced the tripod aspect, not necessarily the tetrapod. So you got to check that fourth articulation sometimes.
Yeah. Greg, can you take us through ways that you classify or think about classifications for ZMC fractures?
Yeah. Traditionally there's 2 classification schemes. The Knight and North scheme, not really used anymore because it was based off of plain films and a Waters view. So a little bit more common now would be your Zing classification because it's based off of a CT scan. So within that Zing classification, it's a type A, a type B, and a type C. So your A is an incomplete zygomatico-maxillary complex fracture, and within that subcategories, A1, just an isolated arch fracture, A2, isolated lateral wall, or A3, an isolated inferior orbital rim. And then your type B is a monofragment fracture of all 4 buttresses. So that's your true kind of classic ZMC fracture right there. But just like many other facial fractures, they can comminute as well, which is where our type C comes in. So still a complete fracture of all 4 buttresses, but with some comminution in there as well. So in my experience, classification schemes are always low-hanging fruit for questions, attending questions or board questions, just to kind of show you have some baseline knowledge of that. So Zing classification, try to remember it. It's what's most commonly used these days.
Yeah, I would say a pro tip that I've learned is when I think about all the facial fracture types and what types of fractures are most helpful to visualize a 3D reconstruction, ZMC is often up there
Mm-hmm.
because you can scroll through the axes and it might not look that bad, but then in the 3D recon, you can see it's really smushed in some way, giving you an appreciation of how bad it is that sometimes the plain film slices don't give you as much. So definitely,
Mm-hmm.
if you're not getting 3D recons for everything, definitely get them for ZMCs.
Yeah, I think ZMC fractures often also give some of the more impressive physical exam findings, because you can really appreciate the, flattening of the malar eminence. You can, see depression at the zygomatic arch. You can start seeing some of your ocular changes as well that, sometimes with a, minimally displaced mandible or Lefort, you're not seeing too much on that clinical exam. But some of these ZMCs, you go up and look from a bird's eye view or a worm's eye view, and you can see some pretty significant facial changes.
Yeah. Especially with them getting crunched. A lot of times they crunch into the face, and part of the reduction we'll talk about is getting them out of the face, which can be quite difficult. But as they go in, and in particular downward, they can also impinge upon the coronoid process of the mandible. So evaluating patients for trismus, sometimes they'll have a hard stop and only be able to open part of the way because of that displaced zygoma is now running into the mandible. So good thing to always check during the evaluation. So I touched on earlier that ZMCs are inherently orbital fractures. We'll kind of get to specifics. We're going to cover that next and a lot of terms associated with it. But that decreased projection is such a great thing to look for. There's a weird kind of old school term that I wanted to mention here. It is a pejorative term that still exists in publications. And that is anti-mongoloid slant. And what that means is that the outer part of the eye is actually lower. And the current term is called a downward slanting palpebral fissure. It's an appearance that can happen due to syndromes and other things. But if you're wondering what that is, or if you've seen that in textbooks, yeah, that's what they're talking about. But that can certainly appear when you have ZMC fractures due to kind of inferior placement of the lateral part of the orbit. What do you think, Grant? Any points to touch on or dive into more on that?
I mean, is the type, how often would you operate on that? Is it usually a non-op situation, or what is that like in your hands?
Yeah, you mean like just an arch fracture?
Well, I guess technically a type A1, the isolated
yeah.
arch fracture, is really the only one that might need to be operated on in that situation. Just, popping that arch back out if there's significant depression. But yeah, to your point, Grant, in A2 and A3, these are essentially just isolated cracks, or fractures that usually don't come with any significant displacement and unlikely would need reduction unless that inferior orbital rim, does propagate down into the foramen, as we were talking about with some of the Lefort fractures, and maybe doing a little bit of a decompression there if they're having some significant, sensation changes.
Okay.
Yeah. And in terms of treatment options, as we're thinking about it through those other types or, larger ZMC fractures, of course, doing nothing is an option versus open reduction internal fixation. I do want to mention that it is, I have taken care of a number of post CMC fractures that were pretty bad and probably should have been done later on. It is really difficult to fix after the fact if you don't fix it and then they end up needing it. It involves doing a coronal and doing full osteotomies of the entire segment to remove and position it. And after having done that a few times, it's one of those things that I generally, if you're going to do it, you're probably better off doing it kind of on the earlier phase. Similarly, there are some fractures that I feel like waiting longer really has an operative difference. And I do think about ZMCs. Did we lose him again?
It's looking that way.
I'm here.
Okay, sorry. I'll pick that up right there. Similarly, there are some fractures that I really think about timing, and timing I found operatively really matters. And ZMCs are one of those. Particularly really impacted or ZMCs that you need to get out and get correctly positioned, doing those within the first 3 days, 3 to 5 days is really helpful. Once you start letting scar tissue set in, even as much as like 10 days, it can be substantially harder to pull that ZMC back out. So if I'm going to do these or offering that to a patient, I wouldn't let this necessarily cook for a few weeks before doing it. You're only inviting issues into your world. Greg, any thoughts on that? And,
Yeah, I agree with that, because mobilizing these is important. But, to your earlier point about secondarily reconstructing some of these once they've healed. As you said, very challenging. I think a better approach sometimes on those when they're, I've seen some of these come in a year later with flattening, is to not osteotomize everything and have a custom MedPore implant made to increase that facial projection. So now you're doing things at a less invasive way while still giving the same cosmetic results. But that can be a challenge when insurance is in the game, because they want to treat that as a cosmetic procedure, because you're not, actually repairing bones. So I've had a couple peer-to-peer reviews that have been a little heated, trying to take care of a patient for that reason, trying to explain that I don't want to take a maximally invasive, maximally risky approach to re-osteotomizing everything. I want to do a minimally invasive procedure to correct their deformities. But as I said, when we start getting into cosmetic type stuff, insurances tend to run. But in my opinion, that's a little bit of a better approach to those when doable.
Yeah, that's a good point. I've done a fair amount of that. Fat grafting to broken in arches just to secondarily kind of fluff that area out. But yeah, a lot of times we're reaching for how do we mask it as opposed to redo the whole thing. Unless it's like horrendous. Similarly, I want to touch on a point of, we said earlier that when they're displaced, they can cause trismus and a true bone-on-bone hit and stop. Similarly, after surgery, when you do ORAF on a ZMC, but personally what I do is a non-chew diet for 4 weeks at least. And similarly, the masseter inserts onto the zygoma. So it's the top part of that. And on the bottom, it inserts the mandible. So when a patient is chewing, they're literally pulling on that zygoma every time. So understanding that and kind of guarding against that postoperatively, maybe every patient doesn't need it, but understanding that and potentially guarding against that risk, I think is at least important to understand.
Definitely.
Yeah.
And what's your preferred approach if we were doing isolated arch? Are you more of a intraoral keen approach or more going with a Gillies and working your way down?
I'm a big fan of a nice Gillies approach. And so this is a little approach that's done within the hairline. To kind of hide it. It can be, I've seen all sorts of different shapes. A straight line, I kind of like doing the letter W. It lets you get down and then reapproximates and hide well. Generally with the Gillies approach, what you need to know is somewhere up in a hidden area within kind of the temporal bone on the side, you want to get down to the temporalis muscle. So that will be first the skin, the subcutaneous tissue, the temporal parietal fascia, and then you'll see that glistening white distinct temporalis fascia. I understand there's some naming nuance that varies between folks. That's how I like to think about it. And then you incise that glistening white temporalis fascia and you're on the temporalis muscle. You slide an instrument down underneath the arch and kind of pop it out. There is some pretty bad ways to mess this up, and that's trying to lever a chunk of that arch outward. If you use like a Selden, for example, you can cause skull fractures by trying to lever off that. You can use, I know somebody who really liked to use a tooth extraction forceps and put one of the handles in as an adjunct. There's actually an instrument that's made for this. I love this. I have a couple peel packs in my clinic for use when we do these called a row disimpaction forceps. It's not a row elevator. It looks different, but it's made to slide down and allow you to put safe force totally laterally without pushing on the skull. I've seen people do other things too, like trying to put a towel clamp in there and pull it out, but that seems a little barbaric for my tastes. One of the interesting things I think is, what do you do afterward? I've seen people use a Fox shield, and this is an eye shield that they suture with prolines around the arch to the outside of the face. I kind of think about that like a nasal splint. It more reminds the patient it has a fracture, but it seems a little overkill for my methods. One thing I just started doing a few years ago was using a large piece of gel foam, and after I pop the arch out, just kind of placing it behind it to just give it some gentle stability for a clot to start, helping to mitigate against it just falling back in when you're done with the procedure. I don't know. What do you guys think? Any tricks or things you've learned during these?
I've used the Fox Shield before, but I usually am not suturing it in. I'm kind of on the same page as you are, where it's really just serving as a reminder. So I'll tape it over the area so that, they know not to push on it. If they roll over while they're sleeping, it kind of pushes on it. They, might wake them up to say, oh yeah, roll over to the other side. So I agree. You're not plating anything. You're not, as long as you're force free in the area, it should stay reduced, especially when you've properly reduced it. You get a little buttressing on that bone and it should stay in position.
What about Greg? How do you approach or think about like a normal ZMC fracture? It's broken at, all of the buttresses, maybe not too comminuted, but in terms of your approaches and points that you get?
Yeah, I always start intraoral. I make my keen incision, do a nice dissection, really try to expose the maxillary buttress, dissect up to the rim, and so that's my starting point. The next incision I like to use, obviously, is to approach the ZF suture, which can be either a lateral brow or my preferred approach, the upper bleph incision. I just think it heals a little bit better, a little more discreet on the scarring, and that lateral tail of that incision puts you, for me at least, right at the buttress or right at the suture line, excuse me. So I open that up as well. Oftentimes I feel like you need to wait to decide if you want to do the rim or not. So if you get your maxillary buttress exposed, you get your ZF suture exposed, and then get those reduced, often it's that final buttress you want to look at is the rim. So I always start by plating the ZF suture first, okay? Because that's going to establish our facial height, to make sure that as you're reducing other fractures, you're not distracting it down. And the nice thing about plating that area, you can still rotate the fracture amongst that, but you're not able to inferiorly displace it. So I get my plate on there, and then I move down to my ZM, get that all reduced with either an L plate or a straight plate. And then I go and look through my keen incision at that orbital rim. If everything's lined up nicely and stable, all good. If I feel like we're still a little displaced there, that's when we need to figure out that next step of either there's an occasional patient that you can plate that orbital rim still through the mouth if they have enough tissue laxity and stuff like that. But oftentimes, if you're still displaced at that area, you're going to want to do one of your lid incisions, whether that's a transconj, mid-lid, or any of your other workhorse incisions to try to properly reduce the rim as well as get a plate across it.
Yeah, I love that. I think there was a big study a few years ago. Teeth and Titanium covered it in one of their podcasts that showed 2-point fixation versus 3 in ZMCs. And from what I remember, it was relatively equivocal because I'm the same way. I'll plate the maxillary and ZF most of the time and only really open up and address the rim and orbit if needed. Because a lot of times if the orbit fracture isn't bad or isn't indicated, then you just don't need to go through the whole rigmarole of exposing it. And I think emphasizing to our younger residents, if that's a high rim fracture or comminuted, you are generally never going to be able to do a good job through the mouth. Like you really have to do some sort of additional approach to do it because you'll probably regret it when you look at the CT scan afterward.
Yeah, you think those plates and screws are going in the right trajectory, and then you look after and you're less than impressed. But my favorite instrument to actually reduce these is the good old Carol Gerard screw. If you get that thing positioned properly, I feel like you can control that fracture, in all directions. You can displace it out, if it's crushed in, you can get some good pull on it. Based on how you're twisting it, you can get it to rotate as well. So, one of the first things I'm doing after my exposure is trying to find that ideal spot to put my Carol Gerard screw. Sometimes that's through the keen incision. There's been a couple times, though, I've done a little nick incision out on the cheek to get a more ideal trajectory on that Carol Gerard screw. So I can get it into really the thicker aspect of the zygomatic bone, kind of where people approach with their zygomatic implants, really getting into that good dense bone and getting a solid screw in there. Because if you just put that kind of more over the anterior maxillary wall or where the sinuses are, you're not getting the kind of control I'm talking about. You're likely going to just pull that Carol Gerard screw out. So I use it a lot for ones that are a little bit more displaced or ones that have been having a hard time getting appropriately reduced.
Yeah. And for our listeners, if you're not super familiar, a Carol Gerard screw kind of looks like a wine opener. It's a handle with a long screw on it. And usually I'll often pre-drill a pilot hole and then screw it in. And then you can kind of pull the zygoma out of the usually crunched in and downward vector of it to mobilize it and pull it out. It's kind of like a joystick on a video game, and then you can kind of use it to help line up as you plate your fracture segments. Sometimes as you get older fractures, I would assume you guys have had similar experiences, like somebody's holding the head down and somebody's pulling as hard as they can, It's always a little nerve-wracking when you exert that kind of force, but sometimes it's needed to actually disimpact that zygoma kind of out of the face. I've certainly screwed up Carol Gerard's and put them in weak bone and then fractured pieces off as I'm doing it and been like, oh God, and then had to fix it. It's not without its own pitfalls, but yeah, I'm the same way. I'll kind of look at the angulation through the mouth and decide if I want to use a trocar. The row disimpaction forcep or instrument is also a great tool that I've kind of gone to. You kind of, from the intraoral incision, you kind of snake it up and behind the zygoma, and then you can very controlled kind of pull it up and out. So yeah, if you're thinking about it or you do a lot of trauma, I'd encourage you to check that instrument out because it can just be so helpful in a number of situations when it's, related to it. Grant, what do you think, man?
I mean, I was just going to ask you, do you do the gillies when you're reducing the arch because you just feel like you have better reduction there versus the keen approach, or how come you're going to
No.
the gillies?
Yeah, I'm only doing the gillies for isolated arch fractures. Through the mouth, the keen incision, what we're saying, guys, is kind of just like a Lefort on one side, just a standard maxillary incision. You can dissect up and lateral on the zygoma, and then usually right there, there's a little bit of very tendinous ligaments attached to kind of the anterior part of the masseter. Once you bovie through that just a little bit, you can easily then get an instrument up behind the zygoma to either pop out an arch that's also with it, or to kind of manipulate and try to pull it up and out. So I only do the gillies as a standalone, as opposed to the keen. But six half dozen one the other. Residents got to get comfortable with all the things.
But to your point, I think with that isolated arch fracture, the gillies is a little bit more of a slick, clean approach to it. That's a little bit less traumatizing as well. Because as you said, as you're having to bovie off those tendinous fibers, that's going to give quite a bit of trismus. That's going to give some pain versus dissecting down, getting under the temporalis fascia and just sliding on top of the temporalis muscle is a little bit less invasive way to get after it.
Yeah. When you're thinking about sequencing these fractures, I do the same thing as Greg, and I think most people, we expose things, we plate the ZF suture first, the zygomaticofrontal, and then kind of the maxilla. If you do need to do the orbit and the orbital floor, like if I know it has to be done or explored, I'll expose it before plating anything, obviously. But if it does need to be plated in place, I will do that last. It's very important whenever we're talking about sequencing of a lot of these, most surgeons do the orbits last so that you have everything around it set and you can ensure all the tissue is free and you're not trapping anything. You guys do the same?
I do.
I do want to mention for okay, what if we take it to the other end of the spectrum and it's a terrible fracture, really bad? Or the zygoma is fully comminuted all and broken right where it comes off of the skull base, right in front of the ear. What zygoma's breaking right there at the zygomaticotemporal suture is a pretty rare fracture. I really only see it in gunshot wounds that hit it or high-speed motor vehicle accidents. But if it's broken there, you still have to and you're going to do surgery on it, reestablish it from unstable or stable to unstable. So to do that, you really need to do a coronal approach. If you do a coronal approach, you can access the entire zygoma from the top, from where the arch takes off from in front of the ear all the way forward. So in really bad ones, you can think about your surgical access and need to do that. I've probably only seen 10 of those in my career. They're not very common. And these days I'm using a custom plate because getting fixation, above the ear and then you have mastoid air cells, it's very limited stock. So I really like to be careful with how I do that. I don't know, any tips on those, Greg, for like the super bad ones?
Yeah, I mean, to your point, you got to do the bicoronal incision, but you also really need to extend that one side down into a preauricular incision. I mean, you're almost doing a TMJ approach at that point, because getting to the root of the zygoma, or root of the arch, you got to be able to dissect posteriorly a little bit as well. So getting good exposure on those is important. But that is a little bit hard to kind of strip all that tissue off and actually get some decent bony real estate to plate. But yeah, those can get a little ugly, but I totally agree. You can access the entire arch as well as zygoma through the kind of combined bicoronal or hemicoronal with that preauricular extension. But usually, if it's that bad on one side, you're probably looking at more of a pan face, and you're going to have all sorts of other incisions open up and other buttresses to work off of.
It is one of my favorite things to do, to drop a coronal and access the entire arch. I really love it. There's such great anatomy and, talking about layers and things. So I love doing that in the OR. Grant, anything to put a bow on ZMCs we missed or want to hit?
No, I thought that was really thorough. Appreciate you guys running through that.
Nice. Let's talk about orbits. There'll be a lot of meat on this bone, so we'll spend some time really hitting concepts as well as anatomy and terms as it relates to eyes that, again, we should know and be in our vocabulary and frequently show up on exams. As we talk about the anatomy, we'll talk about specific issues that are related to certain anatomic concepts, but we're not going to hit everything, particularly soft tissue eyelid stuff. That's a whole different ball of wax, and there's just, that would take this too long. So, we're sticking to the kind of the basics with this. There are 7 bones of the orbit. This does pop up on exams: the frontal bone, the sphenoid, the zygoma, the maxilla, the palatine bone, the lacrimal, and the ethmoid. If you want a good test, mnemonic, you can think about FS Zimple or 5 silly zebras made pizza look excellent. That's hopefully those bones fit somewhere in there. But briefly, the orbit is comprised, the roof has 2 bones, the frontal and lesser wings of the sphenoid. Laterally, we have the greater wing of the sphenoid and the zygoma, like we mentioned. Zygoma's fractures are inherently orbital fractures. The orbital floor has 3 bones, the maxillary bone kind of coming up, the zygomatic bone, and the palatine bone medially. The medial wall has 4 bones, the frontal process of the maxilla, the ethmoid, also called the lamina propria, the lacrimal, and the sphenoid bones. And then we have that infraorbital nerve we all know and love exiting from the infraorbital foramen, and that's about 5 to 10 millimeters below the infraorbital rim. A lot of times as one is learning to do orbital floor repairs and access the orbit, you'll be trying to pull tissue up and out and bone fragments, and you'll see a giant cable-looking white thing running back. That's the infraorbital nerve. Not a good thing to cut if you can help it, but sometimes we forget that nerve lies right on the subsection of the floor there. So you may see it during dissection. Greg, you want to take us through some of the, everybody's favorite stuff on tests, the fissures, what lies in them, and what you might see if problems happen?
And that's one of the difficult parts with orbital fractures. It's complicated anatomy and a lot going on in the orbit. And then there's the globe itself, which, although we know some stuff about it, we're far from experts, right? We're not all ophthalmologists. So, getting a good ophtho consult, before operating on one of these patients, I think is a good practice, because sometimes these patients will have some motility disorders or some globe injuries that you want well documented prior to surgery, so they can be traced and made sure that they're resolving and no one's getting a little extra blame put on them after we've repaired the bones. But yeah, so the first thing we need to think about is the superior orbital fissure. So coming through there, you have the cranial nerve 3, 4, 6, and then the sensory nerve V1. There's also some sympathetic fibers. The superior ophthalmic vein comes through there, and the recurrent and middle meningeal artery as well. This superior orbital fissure separates the greater and lesser wings of the sphenoid, and it also serves to delineate between the orbital roof and the lateral orbital wall. Also, back there, you have the inferior orbital fissure, which would be the sensory nerve V2, parasympathetic branch of the pterygopalatine ganglion, and the inferior ophthalmic vein. And then lastly, a place that I hope none of you find yourself, which would be the optic canal itself, where you have your optic nerve, your ophthalmic artery, and your sympathetic fibers. So it's really these 3 areas that we're often thinking about when we're talking about dissecting in safe zones, because you don't want to be too close to any of these. You want to be keeping your dissections anterior to these areas. But when we're talking about post-op complications or even pre-op complications of orbital fractures, knowing that anatomy is important, because there's something called the superior orbital fissure syndrome. So that would be compression of the nerves that go through the superior orbital fissure. Now, this could be preoperatively from severe swelling or impingement of bones, or this could be postoperatively after you've reduced bones, whether you've impinged on this with a plate with bones, or once again, severe swelling, retrobulbar hematoma, things like that. So with the superior orbital fissure syndrome, you're going to have compression of cranial nerve 3, 4, and 6, giving ophthalmoplasia. You're going to have some lid ptosis from cranial nerve 3 being compressed. You'll see mydriasis and loss of direct pupillary light reflex from the parasympathetic fibers of cranial nerve 3 being affected. And then treatment is dependent on the etiology. So are we talking pre-op, post-op, maybe, so you're always going to have to reevaluate your patient and see what's going on. Might need some new images and things like that. Orbital apex syndrome, very similar to superior orbital fissure syndrome, but you're also having the optic nerve involved. So kind of the same type of symptoms, but also you're going to see some loss of vision and direct consensual pupillary light reflex. So this can also be very concerning and would be coming all from the same reasons. Do you actually have any experience treating any of these, Dr. Jenzer?
I don't. I've never seen one of these clinically. I always think about these on tests as what's differentiating. In orbital apex syndrome, you get loss of vision as well. I have seen some retrobulbar and collections of things back there that manifest similarly, but like you said, I think about it as 3, 4, 6 are the main muscles that move the eye, and there's compression of these, and you get, essentially a frozen eye. It's not moving well because of that. Interesting, the inferior orbital fissure, there's a kind of, I think it's and I'll be speaking a little bit out of turn for our UK and British colleagues, but there was a British paper published, and I learned about this and this methodology of approaching orbits from the great Dr. Ben Heckler, who, listeners might be familiar with. But as opposed to normally, when I do a transconj, I'll kind of go stable to unstable, dissect laterally, work medially, and kind of free up the fracture. Apparently, it's a common methodology in England. If I'm getting this wrong, sorry, English surgeons. Shout out Tom Pepper over there. They actually dissect and purposely find the infraorbital fissure as a start point. So dissecting laterally, generally about 30 to 35 millimeters back, because once they have that identified, then they can work lateral and know they're safe. There's a really short paper that's pretty interesting that has that. So it's kind of cool to think there are other methodologies about dissection based on the anatomic concepts that, you just reviewed, Greg. Interesting to hear always how other people have done it. I've done it a couple times. It does work. Yeah. Continuing with some anatomy things, we have something called Whitnall's tubercle. Now, this is about 10 millimeters below the zygomaticofrontal suture and about 3 to 4 millimeters inside the lateral orbital rim. It's a big attachment point. You get a number of things, including the lateral horn of the levator epidurosus, the lateral canthal tendon of the eyelids, Lockwood's ligament, and cheek ligaments all connecting there. And we call that the lateral retinaculum. We have something called the annulus of Zinn, which is a tendinous ring of fibrous tissue kind of at the apex of the orbit surrounding the optic nerve. That's the origin of the rectus muscles of the eyes. We have a concept that I'm mentioning because I've had other attendings have a favorite point of mentioning this, and it's called the fibers of Corneef. And this is spelled really funny. It's Koornneef, Corneef. And this is a name for the connective tissue septa within the orbit, which is also called, just as we think about like orbital connective tissue of the eye fibers. And it was named after a Dutch anatomist named Leo Corneef in the 1970s, who demonstrated that these tissues within the orbit are actually partitioned, an accessory locomotor system for the eye rather than just loose fatty tissue. And part of this you can kind of see on a CT scan with orbital fractures with some of the enlargement and swelling in traumatic situations. So in case you ever get asked that as a pimp question, you can sound really smart. Greg, are there any like safe zones or dissections or like different artery distances you think about just having as a general knowledge as we approach orbital dissection?
Yes, definitely. So these are usually more on the you're making your measurements from the medial aspect of the orbit. So there's a few measurements all based off of the anterior lacrimal crest. So you have your anterior ethmoidal foramen, which is roughly 24 millimeters posterior to this point, your posterior ethmoidal foramen, which is 36 millimeters back, and then your optic foramen, typically 42 millimeters back. So oftentimes I'll have an instrument in there and I'll mark 42 millimeters on it. And, as I'm dissecting back, putting that in there to make sure I'm staying well anterior to that. Because, sometimes, unfortunately, your fractures progress pretty far back, but it's nice when they're a little bit more anterior. But those are kind of your classic measurements there, your 24, 36, and 42, all off the anterior lacrimal crest.
And it is okay if you guys are doing surgery and you have to get back there and high medially, you can take those arteries. I definitely do that very carefully with bipole and making sure that I don't have a chance of a bleeder retracting, but you can go through those if you need to. I find that particularly the high medial fractures of the orbit can just be very difficult in terms of access and tissues. Orbits in general just can be quite challenging. So yeah, if you haven't gotten humbled or learned in the OR, you may at some point like us.
Yeah, I feel like it's the fracture that, often you can be taking some sort of kind of team approach where you get two people working, two sets of hands. That is just not the case with an orbit. Only one person can see at a time, so you have, the person who's actively working, everyone else is trying to help with minimal benefit, because they can't see themselves. They can't see what they're retracting. You're working in the, an even deeper, darker hole than the oral cavity, so there's just a lot stacked up against you when you're doing orbits, which is, one of the things that make them very challenging.
Yeah. Specific other vocabulary terms before we move on. These are really good to understand for your trauma evaluation and documentation, as well as doctor vocabulary. And so the first one is anisocoria, and that means your pupils are different sizes. Like we talked about in the initial podcast, anytime you have different pupil sizes, you need to get real concerned quick about potential intracranial hypertension. People can have it just genetically, and they know about it, but that's a good reason to get optho involved on the faster side to see if there's a globe injury. A diplopia, that's double vision. And when somebody has double vision, you really want to evaluate, is it monocular from one eye or binocular in both eyes? So you can have them close or put their hand over one eye and see, hey, did your double vision go away? Monocular diplopia is really concerning for things like a retinal detachment or lens dislocation, right? Opthos world inside the globe. Binocular diplopia usually can be a result of trauma or potential muscle entrapment. So you really want to ferret out, is it one eye or both, and where is that coming from? And then we have the term enophthalmos, and this is an inwarding positioning of the globe, usually due to a decreased volume of the orbit. So I think about enophthalmos as meaning the eye falls posteriorly or backward, as compared to the term hypoglobus, which is an inferior positioning of the globe. Generally, with people with larger fractures or as things settle down, their eyeball will drift backward and lower, giving you that strange appearance that, is a reason cosmetically to do surgery, but they mean different things. Enophthalmos versus hypoglobus. And on the other side, we have exophthalmos, kind of bulging out, or hyperglobus, superior positioning of the globe. We also have the term proptosis. This is kind of synonymous with exophthalmos, kind of like the eyeball pushing or bulging out. Obviously, we're usually in trauma worried about something accumulating behind it, right? A retrobulbar hematoma, which means blood, but it can happen from anything. It can happen from infection or other sources that are trapping anything back there. And then we have the word ptosis. And ptosis is just a drooping, usually of the eyelids. And, kind of just the next step in that conversation is really talking a little bit about orbital compartment syndrome, or OCS. We often use the term lateral retrobulbar hematoma to kind of mean this, but it's important to understand that orbital compartment syndrome is a distinct entity. So just like briefly, you can get compartment syndrome in your limbs, anything that traps behind that very small orbit, especially if it can't get out in big fractures, can slowly increase pressure, which can compress the optic nerve in others and lead to blindness. So it can be blood, but a lot of things can cause orbital compartment syndrome. Just to hit it again, we check range of motion, right? Palpate for fractures. We assess the medial canthal tendon. We'll talk about NOEs in a future episode. Evaluate that visual field. Eye motion, check their pupils, and if you have concerns, use a tonopen for intraocular pressures. More focused examinations that I know there might be some surgeons, and I'm curious if you guys are comfortable. I'm not. Usually once I'm worried about globe stuff, I consult optho, but you can use a Woods lamp to look for corneal injuries or abrasions, or do a fundoscopic eye exam. I don't trust myself, and I don't have the experience of doing a fundoscopic exam. I'd want an expert to do it, but I don't know if you guys trained in it and feel pretty comfortable at it, or...
Yeah, no, I'm on the same boat. I like to get optho involved on these things. I mean, it's one thing to pull out a tonopen and test some pressures, but when you're talking about, fundoscopic exams and dilating, pupils and really getting that good detailed evaluation so that these problems can be tracked and treated when appropriate, I think having an ophthalmology consult is important. Now, it can be a little bit challenging in the middle of the night in an ER to find yourself an ophthalmologist, but doesn't mean that they shouldn't be contacted and at least request these types of evaluations. But as you were saying with the orbital compartment syndrome, the orbit has some pretty tight fascia around it. That orbital septum can really, trap stuff in there, which needs to be decompressed. So, as you said, a lot of people are talking about a compartment syndrome, almost using retrobulbar hematoma or hemorrhage as a synonym to it. But as you're listening, it is different. I mean, just because there's bleeding back there, just because there's a hematoma, doesn't mean you're getting a compartment syndrome. It does not mean you need to do a canthotomy, because oftentimes if you have an orbital blowout fracture, it's just going down into the sinus and it's all fine. So it's really oftentimes on some of your more minor fractures that don't have a way for that blood to escape that is building, giving that compartment syndrome. And then when you go and do your lateral canthotomy, inferior cantholysis, that's what you're doing. You're freeing up that orbital septum to allow blood to start getting out past it and back out into the face and drain so that we can decompress like that.
Yeah. A couple more things that you may see or come up. One that you just got to know cold is the relative afferent pupillary defect. This is also called a Marcus Gunn pupil. It's an abnormal pupillary response indicative of optic nerve damage or retinal damage. And to assess this, you do a swinging flashlight test. I would encourage you to look up images and YouTube videos, but you kind of quickly swing a flashlight, and light into the affected eye produces mild to no consensual light reflex on the opposite side. It's lost to that relative afferent kind of connection. Whereas if you do a light test on the normal eye, you still get pupillary constriction on the affected side. So sometimes you can even get dilation during direct eye stimulation, an opposite effect. But that's what a relative afferent pupillary defect is, and common to show up on test and exam, so make sure you know the Marcus Gunn pupil cold. Any of the other terminology or kind of big picture things you want to hit, Greg?
Yeah, there's a few others. Some of them end up being a little bit more red herring type stuff, but still good things to have a command of the information. Traumatic optic neuropathy, which would be decreased vision in the affected eye. Ipsilateral afferent pupillary defect. This is thought to be due to vascular insufficiency, so you need to reduce the microvascular spasms and the soft tissue edema. So sometimes we need to give large dose steroids with methylprednisolone, sometimes some loading doses, continued by an infusion after within 8 hours. You have traumatic mydriasis, which would be a pupillary dilation due to interruption of the parasympathetic innervation. And it results in anisocoria, so those different sized pupils. Treatment it would be with a 2% prilocaine, and then it usually will resolve over several days to weeks. You have traumatic iritis, which would be inflammation of the anterior chamber of the eye, onset usually a few days after the trauma, presents with some dull pain, some tearing, photophobia, and then oftentimes you need to be treating that with scopolamine or cyclopentolate. So these are the kind of things that you want your friendly neighborhood ophthalmologist involved in, because they're just a lot more familiar with this. And then if everyone remembers kind of back from their general anatomy, I feel like Horner syndrome was one of those kind of first couple weeks of anatomy class that we were learning about. So Horner syndrome would be an injury to the sympathetic nerve supplying the globe. So your triad of signs would be miosis from the unopposed parasympathetic function, eyelid ptosis, right, drooping of the eyelid from the decreased Mueller's muscle tone, and then anhidrosis would be from the sweat glands being affected. So that's another one of those kind of buzz type things that you need to remember, your triad of signs: miosis, ptosis, and anhidrosis.
Hopefully, listeners, you're not bored to death. This stuff is important, and we're trying to give you the academic experience so you guys can listen to this and rock and roll. Any follow-up things in that, Grant, things we touch on before getting more into fractures? I think you're on mute, homie.
Sorry about that. No, yeah, that's good. And then you diagnose Horner's with cocaine drops. Is that right?
You can, yes. I'm sure they use other things these days, but one of the few indications to use that, usually 4% cocaine solution. I've used it once or twice during nasal fractures. I actually don't even think it works as well as lidocaine and Afrin, but everybody gets real excited when you get to use medical grade cocaine. In terms of orbital fractures, a lot of times we'll see kind of cracks or linear fractures that don't really have any content herniating out. Blowouts tend to be the most common just because of how fragile the orbital bones are. These tend to happen in the inferior aspect in the floor, but they certainly can happen on the sides or in combination with that. And then we have complex orbital fractures, which, the real world doesn't fit in these boxes that nicely, but extensive fractures involving usually two or more walls. There's three terms that I want to, or a couple terms here to talk about, and that's entrapment and incarceration. So entrapment of eye muscles refers to a mechanical restriction of movement caused by tissue being caught or pinched in a fracture, most commonly like a blowout of some type, particularly in kids where the bone is more green and some of those bones can kind of snap back into position after the fracture, trapping things. So this usually involves the inferior rectus or medial rectus, and it can pinch muscle, fat, or both of them. And what you'll see from this is limited eye movement, right? Typically with the inferior rectus is trapped, they can't look up and follow your finger upward. It can manifest with diplopia and sometimes pain with movement. Incarceration is a term that is a more severe specific subtype of entrapment. And it refers to the tissue being firmly trapped in such a way that it compromises blood supply and creates an ischemic event. We have lack of blood flow and oxygen to a muscle. And these are more kids, trapdoor kind of things, and can result in a permanent dysfunction if not treated quickly. So signs that would clue you into something is entrapped or incarcerated is severe restriction of movement, right? I tend to get real worked up pretty quickly when somebody can't really follow my eyes after orbital trauma. Minimal external signs in kids, it can be very internal to the process, and they may have the oculocardiac reflex. And I think we talked about this before, but it's also called the 5 and dime because cranial nerve 5 is the afferent, and then the dime or 10 is the vagus nerve. It essentially triggers your parasympathetic system, and you can see marked bradycardia, nausea, vomiting, even from somebody trying to follow your fingers and look up or down. If that happens, don't keep having them repeat the clinical thing. You can actually, I've seen asystole happen a number of times from such strong parasympathetic outflow, which is terrifying. So if they start to have those signs, you probably need to go to the OR. When you need to go to the OR, you need to really think about it in more of the urgent emergent context if somebody has evidence, because sometimes it's not clinically nice and easy to determine if it's incarcerated or entrapped. I really like to try to get those muscles freed up within 6 hours, because when you get to start talking a couple days, 2-3 days, maybe a little bit more, then that muscle or, tissue can be permanently dead, and then they don't regain function of their eyes. I have seen that happen. Or, I can still remember some cases where the patient shows up at the ER 4 days after an orbital fracture and trapped, and you're like, we're going to take it, but, the outlook is not good. I don't know. You guys have any experience or things that, usually the bad things tend to stick in our minds a little bit more?
Right. Well, I think what you're speaking to just shows how important doing force duction tests are, because most people with an orbital floor fracture are going to have some up gaze restriction, mostly just from swelling and pain and things like that. So, you're going to get a call from your ED doc. They're going to talk about this limited up gaze. You're going to open up that CT, and your radiologist is going to have some nice CYA comments in there of, concern for entrapment, correlate clinically, and then there you are saying, although it's a blowout fracture, it doesn't look like anything's entrapped on scan. Here we are with some clinical exam findings. So you got to get in there, do some numbing eye drops and do a force duction exam and make sure that eye is able to move. Because as you're saying, if it's true entrapment or even the more severe variation, the incarceration, it's more of an emergent situation, and you got to get in there and actually do something about it versus taking the step back and allowing swelling to resolve and re-examining that patient, 7 to 10 days later. So important delineation to know what's a true entrapment or incarceration versus just some upgaze restriction from swelling and pain.
Yeah, great point. I've personally found patients tolerate force duction in the ER very well without sedation. Like 4% tetracaine drops are pretty normal. And then if you're not familiar with residents, there's these very fine forceps we have that are typically called 0.5s or bishops. And usually you have to crack a set that has them in your, operatory stuff and bring them to the ER to check. But yeah, a lot of times it can be guarding, but that's a great. Have you guys found that patients tolerate it pretty well, or like some people will just take it right to the OR to test it more efficaciously I don't know
Mhm.
where you guys fall on that.
Yeah, I mean, they tolerate it well enough. You're right. You got to get some tetracaine in there, give it some time. It helps to have a second pair of hands in the room to help kind of hold the lids open and stuff because these patients can be a little bit squirmish. But to the point of taking it to the OR just to test it, I mean, it's, I think a little overkill. Sometimes I just counsel the patient, hey, this is going to be a little uncomfortable, but this is a key um, examination finding to know what we're doing here of a step back, wait and watch versus let's move forward with a late night trip to the OR.
Yeah. Grant, anything to hit on before we start talking about what do we do about these things?
Yeah, that was my next question is what's your approach and how do you take care of this?
Greg, you want to lead us in?
Sure. I mean, overall, I personally think I'm relatively conservative when it comes to orbital fractures. I reevaluate almost all of them 10 to 14 days after, letting that initial swelling resolve. Okay. And then really leaning on the true indications for fracture repair. Right. So most people are going to have diplopia early on. Right. So you got to give time for that to resolve and then reevaluate, because if they're having prolonged diplopia after swelling has resolved, or they are actually having anophthalmos, these are true indications. But just having a fracture, even a larger fracture, if that eye doesn't drop, no anophthalmos, no double vision, then what are we really fixing, right? Because these aren't weight-bearing segments, these aren't buttress bones. It's really just loss of that very thin orbital floor bone. So always reevaluate everybody. I don't just depend on fracture size alone. I almost never take these to the OR right away, with the exception of entrapment. So if we have that patient in the office with the prolonged diplopia, with anophthalmos, then it's time to say, all right, we're going to get in there and plate it. If I had my pick of incisions, I'm going more with a subtarsal or mid-lid type approach. I just feel that we get such better, cleaner dissection, better view of the orbital fractures and things like that. But unfortunately, some of these fractures are on young females and they have their cosmetic concerns, which is where sometimes you have to do your transconj incision as well, because it does, hide the incision and any scarring, into the conjunctiva, but it does limit your visibility a little bit. Sometimes you get into the fatty planes of the eye a little bit, which can be a little annoying during your dissection. But typically, if you do a lateral canthotomy with it, you tend to get some pretty good access. So those are my two. I'm rarely doing any kind of, subciliary type incision or anything like that. So for me, it's either a mid-lid or a transconj. But how about you?
Nice. Yeah, I've become more conservative the more I progressed in my career. I want everybody to understand too, I've certainly seen this, orbital surgery is not benign. You can take somebody who's not having issues to fix a fracture that might not need it and then actually cause serious issues or muscle weakness or all sorts of things. It's really interesting when I think about dogma across specialties. Generally, in my experience, I've seen that people who specialize in trauma from oculoplastics or ophthalmology world really tend to be very minimal and very don't treat these fractures frequently. NT is kind of the middle, and I think OMS, we tend to be on the more aggressive side as a large statement. I've certainly heard of people I would say are more aggressive. They open every orbital fracture to take a look and possibly do the thing. Great training, right? But probably a lot of unnecessary surgery. Similarly, how much of the floor needs to go away is an example for you actually to have those clinical signs and symptoms that indicate surgery. I have stopped trying to guess. If you look at literature, you hear generally 50% as a rough estimate thrown out. I've seen people with 80% of their floor blown out have no clinical signs and not need surgery, or 10 to 20% end up needing surgery. It's really hard and patient specific. I've seen so much variation that, like Greg, I kind of stopped predicting it because you just can't. You just follow them individually and see. I will say there are advantages to operating early. Some orbits, if you go in 24 hours, pulling the material back up into the orbit to get a reconstructive plate or material underneath is really easy because it's fresh. The longer you wait, the more things tend to scar in and the harder it gets. I changed how I approach these a little bit when I got to work with Dr. Powers, who is not afraid of following orbits for weeks and taking them a month or 2 months or 3 months later, because the pro tip is you change your dissection strategy and use a jewel or bipole to get through the material as opposed to trying to doggy paddle all of it back up in the orbit. So that really alleviated that. Usually people think, okay, within 2 weeks, because the scarring, we have to make that decision. So You see a lot of different things out there based on the specialties, but it's always a high point of contention, I think, in the literature about it. And I don't have any answers for you, but I think a little bit more conservative, patient-specific evaluation is really the way to go with it.
Earlier, you had mentioned the infraorbital nerve running through the floor, and that's the hardest thing to get that orbital contents off of when you have waited for surgery, because it is starting to scar in. So realistically, that infraorbital nerve is supposed to stay down and everything else come back up. And, separating those planes and establishing that for sure can be a challenge, a few weeks or a couple months into this. So, but I still think that wait and watch approach. Now, when it comes to actual plating, we do have some options there. Some people will just use a straight mesh that they're going to bend themselves. They do make a lot of the companies now have these pre-bent orbital floor plates that are based off of volumetric averages of patients. You can choose to have your mesh wrapped in Medpor or not. And, or if you're taking a really old school approach, I've seen people even use some bone products to put down there, like, whether that's a bone graft harvested from somewhere else, or sometimes some bone coming out of a bottle. But my preferred approach would be to use one of our pre-bent volumetric averaged titanium plates with a Medpor covering. Now, granted, those are really there to reconstruct the entire orbital floor and oftentimes even the medial component as well. So you end up cutting these things down quite a bit, just to get them to just reach the edges of your fracture. Another point, everyone always talks about to make sure you're dissecting back far enough to reach your posterior ledge of your fracture, because you don't want your plate to be falling back or to be lower than what you expect it to be. And then as a general theme, I do agree with this, but if you've found stable anterior, lateral, and medial bone, so you have your 3 points that this thing is all on, the back can't really drop down, so if you're going to be maybe not getting onto stable bone on the lateral or medial aspect, then for sure you need to make sure you at least reach a posterior edge. But getting to that posterior edge sometimes is the more challenging aspect of all of that.
Yeah, totally agree. 2 principles that I always think about when I'm approaching these is, 1, I never operate on both eyes if possible. Panface, trauma, because in a worst case scenario, if during surgery you blind somebody in one eye, you may not do surgery on the other. So even if I have to break up surgeries, I kind of try to do that whenever possible. The other thing is, I always do probably like all of you guys, a forced duction test before surgery in the OR and right after I put the plate in, because I've certainly caught things that I've impinged upon and the eye can't rotate. I like to prep the other eye that I'm not doing surgery on into the field and put a corneal shield there. Because if your forced duction test you're not sure if it's good, you can go to the other eye and have a stable reference for what normal feels like. And it's one of those things, you don't need it until you need it, but it can save your butt one day and give you a good frame of reference. I've experimented with all the things. Interesting, Greg. I've found personally that the impregnated meshes, like the Titan plates, for example, that Stryker has, I think the thickness of them can tend to rub on the ocular muscles a little bit and cause a little bit of, not restriction, but a little bit of pain with gazes. So I've kind of moved away from that, although I'm also lucky to be at an academic center. I do most of these custom VSP these days. Some pro tips with custom. So I always try to make my custom plates extend to the lateral aspect of the orbit, kind of on the floor where it transitions laterally, because it registers really well. It clicks in one place. If you design a plate to sit in the middle of the orbital rim, you're not really going to get that left and right as much as you can if the plate clicks in. The other thing is understanding the stock thickness of that companies make these is usually 0.5 to 0.6 millimeters. They're really hard to change in the OR. And just like using a Titan plate or whatever, you generally need to trim them down pretty substantially. So you can ask for them to be made as thin as possible, which is usually 0.3 to 0.4. And it allows you to use a wire cutter to easily trim them in the OR and adjust them. I really like doing that. Sorry, I know I interrupted you, brother. What do you got?
I say, yeah, anytime you can go custom on these, infinitely easier for sure. And that, bodes well when you're doing this kind of a little bit more of a delayed approach to them. Because like I said, that way, if you're registering off of something off of the lateral aspect of the rim, anterior rim, then you're going to reach your posterior aspect, you're going to reach your medial aspect. without as good visualization. Now, if you're in a situation where you are maybe don't have that available, you don't have some of the pre-bent plates, and you're going to use a traditional mesh, I usually am trying to use some sort of template to help me with that size. So oftentimes I will use one of the metal kind of suture packs, whether it's a chromic or something like that. It has that foil wrapping on it. So I take that out and I start using that as a template, and I put it in the orbit and start making sure I'm hitting those medial and lateral walls and then trimming that down until I have a nice little template. And then I go and put it right up against my mesh and cut it to that size versus it's a lot easier to come in and out of the orbit a whole bunch of times with that metal packet than it is the plate itself, because sometimes as you're cutting it, it has some sharp edges. It's starting to, catch on some of the soft tissue, inducing more trauma as you're going. So having a nice template in there to get a better idea of what size plate you should be using is helpful.
I do think there's one important thing to understand too about material selection. If you're using a mesh titanium plate and you're treating usually a floor fracture of some kind, you're leaving channels for the blood to drain afterward. If you're using an impregnated plate or other materials, sometimes that can be so thick that if blood were to build up afterward, it doesn't have anywhere to go. And that's important just to understand during that postoperative phase, if you're setting somebody up in the more likelihood for getting a retrobulbar hematoma postoperatively, which can happen. So just something to think about. I do want to mention there's a very cool sinus approach. I have put in endoscopes to look at the inferior part as I've done these before, but I haven't done. My friend Yotam Rabinowitz at VCU does a lot of this and published on it, as well as Mark Engelstead at OHSU and their crew, where they essentially use a piezo to remove pretty much the entire anterior maxillary sinus wall and then get up into isolated floor fractures. And at VCU, they like to use a single straight plate along the bottom to kind of gently hold things up. Or Mark likes to, use something like a little Simpor or like squishy material with some give to dissect up and put up underneath the fracture and prevent an eye approach entirely. So there are some cool things out there. I haven't had a chance to do it yet, but I saw Mark lecture on it recently at ACOMS and I'm looking for the perfect fracture. There is some terminology that's helpful to understand too. And one of these in the surgical world is called the frost stitch. Or frost suture. And this is a temporary traction suture that's usually placed at the end of surgery. It's different. Sometimes I like transcons, or even better if there's a lac on the face I can take. But during a transcons approach, a lot of times we'll throw sutures through the superior tissue to help retract up and aid in visualization. That's not a frost stitch. A frost stitch you put at the end. It's usually a 5/0 silk or nylon. You pass it through the lower eyelid, typically through the tarsal plate or just below the lash line. And you can throw one or two of these. And then you kind of pull it gently up to the forehead and put some steri strips and multiple layers to kind of hold everything up. And the point is it causes gentle upward traction and it helps resuspend things theoretically. It's usually left for about 24 hours or so. I don't typically use this. If you do it a little bit loose, you can still evaluate the eye, but if you do it tight, you lose the ability to check somebody's visual acuity afterward, which I really want to do at numerous points in the postoperative period. So if you're going to do it, leave it just a little bit loose so you can still check the eye. This is not backed by science at all, but one of the things I've learned from my mentors and personally is that when you put a frost stitch in, it actually helps fractures release blood and drainage a little bit. I don't know why that is. I don't have any basis for that. But I'll often reach for this if the orbit is particularly bleedy or I'm really more concerned about a retrobulbar hematoma developing. I think the upward tension on it helps the blood egress if it's kind of pooling there. And I've noticed that postoperatively. So just a random pro tip from my experience. I don't know if that's, but don't quote me on that. There's no papers or anything that back that. I don't know. Greg, you got anything to add to that?
No, I've definitely used the frost stitch before. And with that, I think if you put a piece of tape up on the forehead prior to the frost stitch, so you can, and then put a second piece of tape over the silk itself, it's easier to kind of take down and put back up so that you can check visual acuity a little bit easier. And then it'll stick back down pretty easily.
I guess pursuant to this too is lateral canthotomies and inferior cantholysis. So you can do this in conjunction with a transconj incision. And, I would, if you're not familiar, I'd recommend checking out Atlas and videos about all the steps in anatomy involved in more detail for some of these orbital approaches. But by adding in the lateral canthotomy and inferior cantholysis, you extend your dissection and allow you to really access the lateral orbit more. I have met surgeons before who do that in every floor they do. I think that's a little aggressive. Again, disrupting that ligamentous structure. Yes, you can resuspend it afterward, but things can go wrong. So I only really do it if I need access to that entire area. Similarly, medially, you can do either what's called a transcaruncular addition to the incision or do it by itself to really gain better access medially. I kind of prefer a retrocaruncular, just going right behind it, but you can add these into a transconj to extend the dissection if you need access in very large orbital cases. But they're tricky a little bit, especially, anytime I'm dealing with eye stuff I'm not comfortable with. We operate a ton with our ophthalmologists, and I love them because they're experts and they're great teachers for me and my residents. So, anytime you're not certain, get help. You don't have to be alone in these cases if you don't feel super comfortable with, more involved things.
What are some of the complications that can arise from in treating these fractures?
Greg, you want to take us through some of these?
Yeah, sure thing. Just like any other ORIF we do, we have to think about hardware problems and infections. There's bacteria, that's coming in from the cutaneous aspect, bacteria coming up from the sinuses, things like that can cause infections and things like that. Hardware can also migrate. I always do like to put at least 1 or 2 screws through my orbital plates, through the inferior orbital rim. So they always have those little extensions that come off that fold down, and you can put a couple so they don't migrate. Now, one of the benefits of using MedPore, a MedPore covered plate, is that if you do need to go back in and remove an orbital plate, because what I've seen in the past is when you're using just a pure titanium, there's a lot of ingrowth of tissue, and they get very challenging to remove, versus that smooth surface on the MedPore can be nice. So just one thought there. And then depending on your approach to the orbit, whether it is through the cutaneous lid incisions or through the transconj, you're going to open yourself up to either ectropion or entropion. So these are problems with the way that the lid heals. So ectropion would be happening from shortening of the anterior lamella, typically with either a subciliary or mid-lid type of incision. And then repairing that can be a little bit of a challenge, oftentimes requires a referral over to oculoplastics, but they do this procedure called a tarsal strip, so that they can kind of re-secure the tarsus properly and tighten it back up so that you're not getting that outward folding of the eyelid. And then entropion would be kind of the opposite, happens more frequently with a transconj incision. So that's shortening of the posterior lamella, where you get the lower lid starting to turn in, which can then be very irritating because the eyelashes and things like that start to rub the patient's eye and can also cause some problems as well. So these also need to be repaired, and oftentimes actually require some oral mucosal grafting to then lengthen that posterior lamella and get that eyelid to be able to fold back out. But these can both be challenging things to repair.
Yeah, I had one of these, and if you do enough orbital surgery, you'll see these. My experience working with a lot of really good oculoplastic surgeons is our ability to really diagnose nuance in this area is not near them. I always get help on this because determining what needs a graft versus just a strip, there's a lot of nuance there. I had a guy within the last year who we did a big custom orbital recon, big fracture, went amazing. Perfect. And he had some entropion afterward. And I watched it for a few months and we did a little bit of eye taping and it got a lot better, but it still had a residual thing where it was semi-irritating and rubbing. So with optho, not too long ago, we went in to, do a lateral canthopexy and resuspend the tarsus, but turns out it was so mild he didn't even need it. And there's something called a Quickert suture. And pretty much we used a 5.0 chromic to throw a few sutures like through the eyelid to just gently evert the eyelid. And he was perfectly fine with that. So there's a lot of gray area nuance within this. Even understanding it, seek out that extra help because it can get weird. To your point, Greg, I'm a big fan. This is another funny debate point about do you put hardware screws in, right? I usually do one or two because I like to secure it and prevent rotation of it. Generally, when you're trying to put screws in, as a pro tip, you want them to go in as vertically as possible. The more kind of anterior, like you make them into the rim, it kind of can kick the back of the plate up, causing rubbing and all sorts of issues. I had an ophthalmologist friend who the patient, and similar, like not only with screws, but I'm like you, Greg, I put a couple buried sutures in like a transcon just to gently hold things together, kind of deep sutures. He's like, the patient called him and I sneezed and my plate came out. And he's like, no, you didn't. And the patient shows up the next day and he's holding the orbital plate in his hand. And the ophthalmologist was like, ever since then, I then put screws in and a couple sutures to help close things. So a lot of people don't. They just set something in there and let things kind of heal. But, you'll find some weird times when that doesn't happen. I think that the hardest part about orbits is the soft tissue because you can't predict how it's going to respond, not only from like trauma, but from surgery. So you might put a plate in and do a perfect job reconstructing the bony contours, but then just from scarring and contracture, they can almost develop what looks like a volume loss. So it can be very difficult sometimes, or you might do a great surgery and they still have either persistent enophthalmos, hypoglobus, or diplopia. And generally, if surgery, and I have had this happen where there's bruising or damage to the eye muscles even before I do surgery that just don't get better. And if that happens, usually they need very special complex glasses with prisms in to help them see and prevent that diplopia from being debilitating. But it's a very messy thing for patients sometimes. Kind of last, to wrap it up, I do want to hit one important topic called sympathetic ophthalmia. And this is an autoimmune reaction that can happen from penetrating eye trauma. So when your eye has, say, a stick in it, your globe, and the tissues inside that are what we call the uveal tissues, UVEAL. And those tissues inside your eyes have very specific proteins that only exist in that place. If you have injuries and your body gets exposed to it, it can cause an autoimmune reaction that can kill the other eye, and then you go blind. And that's what sympathetic ophthalmia is. Most of the time, if it does happen, and it's rare, about 80% of it will occur within 3 months. But what's interesting to understand is if you look at the literature, textbooks, it'll say, how frequent does this happen? And it's somewhere between like 1 in 800 to 1,000. Looking at literature over the last 30 years or so. So, 20, 30 years ago, if you have a stick in your eye, they may elect to, instead of trying to repair it, just take out the whole globe so that your other eye is spared and you don't go blind. More recent studies, broadly speaking, indicate that the rates of this happening are less than we think, about maybe 1 in 3,000. I had a really good conversation with the head of Hopkins ophthalmology about this and his opinions on it. And ophthalmology in general has gone away from just taking out the whole eye and more in general as to trying to repair it and get the eye healed to some degree because we're less worried about it. And now we have things like immunomodulators that can help. However, some things that need to be thought of are the terms when we think about taking out eyes. So the first thing we have is called evisceration. Kind of like, you picture like a samurai or sword combat kind of slicing across the abdomen and everything spilling out. Evisceration of the eye is a similar thing. You can cut the eye open, take out the contents while leaving the kind of sclera plus minus the cornea. This is ideal if you have an eye injury, but it's rarely accomplishable in the setting of trauma. So usually we have to go to the next one up, which is enucleation, removing the whole globe and all the uveal contents, versus the last term, which is exenteration. And that is removing the entire orbit and all the contents. Think like malignancy or cancer, right? Just whack it all. Most of the time in trauma that I've dealt with, we have to do enucleation. We have a gunshot through the eye. We have to take it out. It's really fun because you dissect out the optic nerve and then, clamp it and buzz it, the thing we try to avoid all the time. But it's a very insightful process to go through, along with understanding what Maxface Pros has to do afterwards. So a good idea to get experience with your ophthalmology teams if you're at a center to, get kind of comfortable through the process of removing an eye, using 99% alcohol dehydrogenase to denature and kill the proteins to prevent sympathetic ophthalmia. But whenever you're thinking open globe injury, that should at least run through your mind that somebody's tracking that to help make sure it doesn't happen or catch it early if it does.
Awesome. Well, this has been fantastic. I really appreciate both of you guys running through this. I know it's been a little lengthy, but I mean, great content. And I think this will be very valuable for our listeners. Any last minute comments about this?
Yeah, eyes are just a tricky thing and you just need a lot of reps and experience. Don't get help to reach out for other senior surgeons and friends in ophtho when you're doing these in combination. And I forget if we mentioned it earlier, but we have our dates for the St. Louis Oral Boards Review course, October 8th through the 10th this year, 2026. So come join us in St. Louis to ideally get tuned up and successful on the oral board examination. Greg and I will be there, and we love meeting people who come. So that's generally one of the best things about the course. So we'd love to meet you there as well.
Yes, awesome. Well, if you guys are good with it, I'll put your contact information in the show notes and also the link to the course. And look forward to the next episode.
Awesome.
Oh, sounds great to me. Appreciate the time.
Thanks, guys. Have a good one.
Thanks, Greg. Thanks, Andrew.
All right.
Bye.
Yeah. Thank you so much for listening to this episode of Everyday Oral Surgery. For more information on these podcasts, please visit everydayoralsurgery.com. I love feedback and would be very grateful if you would reach out to me via my email, grantstucki@gmail.com, and let me know what you thought of this episode. Or you can text me at 720-441-6059. Additionally, if you have any topics you'd like to hear about, or if you would like to be a guest on the podcast, please email or text me. I found many of my interviewees through people who have been contacting me and have been listening, and I've gotten so many great ideas for more podcasts, and that's what helps keep the podcast rolling. So I really appreciate you making that extra effort and helping me out with feedback and knowing what to do next on the podcast. Thank you so much.